Saeed, are you there? I don't know what's going on, man.
He is here right now.
Okay, yeah, this is actually very strange. It lets some people in, doesn't let other people in. So we'll figure it out.
Yes, yes, I'm just making them in. It's gonna be okay, I guess.
Hey, Dr. Cabulo.
Hello, Dr. Bennett. How are you?
Hey, how you doing?
I'm fine, thanks. And you?
Very good. Very good. How you been?
Oh, okay. I'm okay.
You're in Congo now, right?
Yes, I'm in Congo now. I'm
Okay,
home.
very
Yes.
good. So
Good.
I guess like everybody else, you're kind of staying close to home.
Sure. Hope you are safe.
Okay, we'll see you when we start, a few minutes, okay?
It's okay.
Hey, Helen.
Yes, yes.
Hey, Helen, I'd like you to meet Dr. Kabula. Are you there?
Yes, I'm there.
I'd like you to meet Helen. She's a medical student from Turkey. Hey, Helen, you need to put your video on.
Hello, hello. How are you?
I'm fine, thanks, Helen. And you?
Fine, thank you.
Okay,
I've
put your
been in
picture on,
Turkey.
Helen. Put your picture on.
Okay.
I've been in Turkey several times for IBMC courses in Antalya.
Yes, Antalya is a really excellent city. I am in Istanbul
Yeah.
right now.
Oh, okay. You are in Antalya right now.
Yeah, no, Istanbul actually. Have
Oh,
you
you are
been
in
in
Istanbul.
Istanbul?
Several times.
Yeah, Istanbul is better for sea. Antalya is bad. Istanbul is an historical and amazing city. Did you
Yeah.
like it?
I like, of course, every time I used to go to Antalya, I was staying in Sefako in Istanbul before I go to Antalya.
Yes, yes, of course.
That must be an
Yeah.
amazing city. Amazing.
Yeah.
It must be. So you like it.
Teşekkür.
You went to a workshop there, right, Dr. Kabula?
Yes, I went for a workshop. I went for IBMC International Basic Neurosurgery course in
Okay.
Antalya 4 times. I went for SIMS course on neuro-oncology at Koç University. Then
Oh,
I
okay.
attended also the WFNS
Oh,
course
okay.
in 2017 in Istanbul.
I am in
But
Istanbul University.
wow, I've been there also, I think twice for holiday. It's a nice town. I enjoy it.
Yes.
Yeah, it looks like a wonderful place.
Yeah, sure.
I've been there just at the airport, that huge airport.
Yes. Which one are you talking about? The Atatürk or the
It's
new one?
the new one.
The new one, yes. Mhm.
Wow,
Very
you know,
big.
that's the only.
The busiest airport in the world.
Well, that's the only airport I've ever seen where you can sleep at the airport. They have beds for
Yes,
people that have a
sure.
layover on the flight, but I'm not alone. You know about that, right, Helen?
Yes, yes, yes. Actually, I thought that the airport in Amsterdam was the biggest one, but I
Oh,
don't know.
I don't know.
The
Yeah,
Istanbul, the new one is bigger than I'm not
yes,
sure actually.
sure. I did also an attachment at the General Pasha Hospital with
Yeah,
Professor Kafada.
yes, yes.
Yes.
Yeah, we're trying to get Helen to get the Turkey community together. Dr. Kabula, you still there?
Of course, I'm there.
Yeah, the Mustafa, the Turkish doctor that always gives webinars and webcasts.
Sorry?
You know Dr. Mustafa, right? At
Yes, Dr. Mustafa, I know
University of
him.
Wisconsin. He's from Turkey.
Oh, he's also from Turkey.
Yeah, you knew that, right, Helen?
Yes, 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 I knew that.
As you know, he's very well known in neurosurgery
Wow.
education.
Sure,
Very,
wonderful.
very. I have an idea about that, Helen. I'd like for you to approach him and to say you want to give him to give a webinar in Turkish.
Okay.
You think he could do that, Helen? Get a group of people?
Yes, yes, I can do it. My school is really good, and I think I can do that. My teachers are really positive about it. I mean, being international like this, they are open.
Okay. We're willing. I'm willing to do them in Turkish, but I think Mustafa might like that to give
Yes,
to his native country in Turkish. He might like that.
yes, yes, yes.
So
I
I'll
agree.
approach him, and you can approach him too. And if you can start getting the students together, You know, it's a
Yes.
lot of doctors like to give lectures to their own countries, you know.
Yes, yes. Actually, he is a really positive. I have sent a message to him about can I do an internship with him. He told me about COVID-19. This is
Keep trying,
yes,
You keep trying. You got a good in. Matter of fact,
yes,
there was a girl here that came to a big webcast. She had been at Mayo Clinic with the doctor that was giving a lecture,
yes, yes.
and
No,
she
yes,
hadn't seen him, and she said, "Oh, how you been? I haven't seen you since you were in Minnesota."
yes. No, I'm not going to give up. Actually, this is 1, 2, 3. It's going to be in which one? I don't know, but sometime one time.
Well, you got a goal. You got a goal,
Yes,
and it's very achievable, and it's very you'll meet him online. Hopefully, you'll meet him online and be able to talk to him. It's so much more powerful than just a
I hope
picture,
so.
or an email, or so much more powerful. 5 seconds of FaceTime is
Yes.
worth a million emails. Hey, Victor, how you doing?
Hello, how are you?
Bien, bien.
Dear
Can I
John
introduce you?
Bennett?
Helen Varayudanos.
How are you?
Yeah.
I was in Spain because I
Oh,
remembered
thank you
you
so much. Where are you from?
from Turkey. Actually, we have met before.
Where?
Oh,
In Spain?
that's
Spain
good.
webcast, Spanish webcast. I meant.
Oh, yeah. Okay, yeah. Yeah, Victor's bilingual.
Yes,
Dr. John Bennett speak Spanish very, very well.
I want to learn Spanish, but it has to take. It takes time to learn a new language. So
It's very
being
similar
a
to it's muy similar a inglés. Gracias a Dios.
yes,
Hay muchos
Have you
americanos.
ever met Prof. Schbeck?
this lecture is going to be very interesting because of the cases that are going to present our friend Ibrahim are not common. For
Oh, okay.
example,
Okay.
toxoplasmosis is not common in the spine.
In the spine. Okay,
So
yeah.
really, really, really interesting.
Let me see. Dr. Sabea, you there, right? Well, where is Raham? Okay, maybe Dr. Sabea is not available yet.
I can see him, my father, Professor Schbeck. I always call him father. The biggest teacher, one of the biggest teacher in the world.
Yeah, you come to these a lot. Let me see here. What do I want? Dab.
Hello,
Hello,
Dr. Ibrahim.
hello, Dr. Sabea.
Nice
How
to
you
see
doing?
you. I'm fine,
Nice to
thank
see you
you.
too.
Thank you.
Yeah, you have your number one fan, Dr. Kabulo.
All of them are friends and colleagues.
Hey, Victor.
Hello,
Tell
yes,
Dr.
yes, John.
Sabea about your case you want to show.
Yes, I think it's going to be very interesting. The
Sure.
toxoplasmosis in the spine is not
Yeah.
common.
That's good, very good.
Yeah, thank you so much.
Okay. Well, yeah, the Kahoot. I have a question about the Kahoot, Dr. Sabea.
Yes.
There's a couple of questions that has all of the above. Question 8 and 9. Here, let me see. I
Yeah,
don't know
which is E.
yeah, but there's no option for E. It only goes up to D.
Whatever, yeah, D, whatever, yeah. The last one. It says
I'll change that to all of the above.
Sure, all of them.
Yeah,
Yes.
that's a solution. I just came to that conclusion under pressure.
Right. Right.
If you don't get a chance to talk to Helen after this, Dr. Sabea, Helen is a medical student from Turkey.
Hello, Helen. How are you?
Hello, nice to meet you.
Nice to meet you
I'm
too.
fine. You?
All well. I've been to Turkey many, many times, and I have lots of friends there.
My father's name is Ibrahim too.
Right. Good.
Yeah.
Ibrahim is a common name in Turkey and in Jordan.
Yes.
Yeah, we'd like to get Helen, get us the Turkish community together,
Yeah,
hopefully,
absolutely.
and help get it together.
I remembered I have been in Jordan too, I guess.
Yeah. Good. You can visit again all the time.
I hope so.
Sure.
Okay, Ezra Dab, she's going to host.
¿Todo bien?
Okay,
No sé.
hello, Radab.
Hello, Dr. John.
How you
Good
doing?
evening.
Hello,
I'm
Nida. How
fine.
are you?
How are you, Professor Ibrahim
I'm fine.
Smail?
Thank you. I'm fine.
Yeah, all I'm going to do, Radab, is introduce you, and then you introduce Dr. Sabea, okay?
Okay.
And that's it. As simple as that. Wait, I hope your camera's working. Is your camera working, Radab?
Yeah. But I can't see you, Dr. John.
Oh, there you are. There you go. Okay. Okay, we're ready to roll. 10, 9, 8, 7, 6, 5, 4, 3. Let me move the spotlight first. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. I don't even have my camera on. I made a mistake there, Helen. But anyways, we have the Jordan Neurosurgery Grand Round with Dr. Sabea. I'd like to introduce a new host, Radab. How you doing? I'll turn it over to you. Go ahead.
I'm fine. Thank you, Dr. John. So we are privileged again by Dr. Ibrahim Smail, who was going to present one of the unusual and uncommon presentation today. He's one of the topmost neurosurgeons in Jordan and well-known neurosurgeon in the Middle East. Has been a second vice president of the WFNS. And we are honored to have his presentations this evening. Dr. Ibrahim, would you please start your presentation?
Sure. Thank you, Rida. Thank you, John. And it's again an honor and pleasure to be with you all today, friends and colleagues. And this is Farah Medical Campus, where I'm working in Amman, Jordan, and from where I'm transmitting. I usually put this black iris, which is the symbol of Jordan, to carry the title of the presentation, the unusual, some of unusual intradural spinal lesions. I have so many, actually I have something like 15 cases, but definitely we cannot present them all today. So I'll just go through 2 or maybe 3, and if we cannot finish, then we leave the rest for the next week. So let's roll. My personal experience with the intradural spinal tumors is something like more than 500 cases over the years between 1990 and 2020. The case I'm going to present today is called IgG4 related hypertrophic pachymeningitis. And as usual, we'll take the case from the clinical, radiological, operative and pathological point of view so that we can put them together. Sometimes people would call them IgG-related hypertrophic pachymeningitis because it's affecting the meninges of the brain, but the common name for other organs is IgG4 sclerosing autoimmune disease. This is really a recently defined emerging entity. It's just new. Kamisawa from Japan reported the first case of a pancreatic lesion with autoimmune disease in the Journal of Gut 2003. So this is the first IgG4 related disease of the pancreas reported in 2003 by the Kamisawa. What is this disease? It's a mass-forming inflammatory reaction. So it's an inflammatory action and it will form a mass, and this mass is rich in IgG4 positive plasma cells. This is associated with fibrosis and obliterative phlebitis, and this can affect any organ in the body, including central nervous system. So in most of the cases, it is multi-system involvement, and it has a progressive course. So the basic criteria of the IgG hypertrophic pachymeningitis is lymphoblastic infiltrate, lymphoblasts, plasma cells rich with IgG4 positive, obliterative phlebitis, fibrosis, and diffuse inflammatory reaction. These are the mainstays of this disease. So again, if we look at it again, lymphocytes constitute 80%, B cells being positive for CD20, T cells being positive for CD3, CD5. Then we have the plasmocytes, 20%, and these are kappa positive, lambda positive. But remember that we need more than 10 plasma cells positive to diagnose this disease. What are the causes of this disease? It could be primary, idiopathic, which is something like 50% for primary, 50% secondary. Primary means idiopathic, we don't know the cause. Secondary to something, to autoimmune disease in 30% of cases, infection, sarcoidosis, and others. So in all, secondary IgG4 related disease, the main one is autoimmune disease, including rheumatoid, Wagner granuloma, IgG4 related, systemic lupus erythematosus, pseudotumor, and other illnesses. Or you can see it secondary to postoperative. We all have seen thickened dura after surgery and thickened dura after radiation, after infection, whenever there is a tumor there, metastasis, for example, lymphomas, granuloma of tuberculosis, granuloma of sarcoidosis, vasculitis. So whenever you see a thickened granuloma, thickened dura per se, it has so many causes, including autoimmune disease and including IgG4. If you look at the hematology of this disease, elevated gamma globulinemia, elevated IgG, and elevated subtype IgG4, and presence of autoantibodies. If you look at exact numbers, we see increased serum immunoglobulin G4 subtype, subclass of IgG4, it is increased, but that is only in 60% of cases. So if you are waiting to see that or to diagnose the case because there is increased serum IgG4, you may fail because it's negative in 40% of cases. So IgG4 could be normal or elevated in this disease. And then you take the ratio between the IgG4 and IgG, it has to be more than 40%. So you need both criteria to diagnose. Since the Japanese reported this back in 2003, it has been reported in nearly every organ in the body. But interesting enough, 80% of these patients came from Japan. Look at this pathophysiology. High serum immunoglobulin, plasma cells rich with IgG4. It can cause Nicolaides disease. It can cause Riddle's thyroiditis, mediastinal fibrosis, prostatitis, pseudotumor of mammary gland, sclerosing cholangitis, hepatitis, autoimmune pancreatitis, interstitial nephritis, erythroperitoneal fibrosis, and of course lymph nodes, pachymeningitis, and this important disease, autoimmune adenohypophysitis. So it can affect many of the organs, pancreatitis, hepatitis, sialadenitis, in lungs, interstitial pneumonia, as we said, in thyroiditis, lymphadenopathy, and in the CNS, it will cause sclerosing pachymeningitis. So this is some of the affection of dacroadenitis, parotid, lung, pneumonias, and etc., and fibrosis of the pancreas. Let's now concentrate on our topic, the IgG4 CNS involvement. It is called sclerosing hypertrophic pachymeningitis. And pachy means thick, so we're talking about thick meninges. That's the terminology of it. And this thick meninges, pachymeningitis, could be focal, could be diffuse thickening. It affects the cranial dura in 80% of cases, spinal dura in 20% of cases. So the common site is cranial. And if you take images, whether cranial or spinal, it can mimic any tumor, it can mimic any lesion. So put that in your differential diagnosis because it's very important. It will cause dural mass or extradural mass or intradural mass. And these masses could be solitary, multiple, diffuse, or nodular. And they are hypointense on T1 enhanced as well with contrast, and are hypo on T2. Let's look at some of the images of cranial pachymeningitis. I collected this for you. You can say easily that this is an F2 with multiple meningiomas. Again, here the same thing, sarcoidosis could be on the cards, multiple lesions involving the pituitary and the stalk, optic nerves, and here in the orbit. So this is a very important differential diagnosis to keep in mind so that you will not miss. This paper, 2012, IgG4 related intracranial hypertrophic pachymeningitis. Again, from Japan, you can see these lesions which you can easily pass as meningioma and so on. It can affect the pituitary gland, and in this case, it will cause hypophysitis, whether anterior hypophysitis or posterior hypophysitis, like in this case. I have a few cases of hypophysitis. I will present it in a future presentation. The neurological manifestations of hypertrophic pachymeningitis, again, this case tells you the whole story. If we take the images of the spinal pachymeningitis, again, it will affect the spinal canal, it will affect the nerve roots, it may go outside the paraspinal muscles, and vertebral arteries can affect them. And this mass could be extradural, dural, or intradural extramedullary. Examples of the spinal, this is a mass surrounding the spinal cord, or just on the edge here, here surrounding the cord, here is anterior to the cord, and here is anterior and posterior to the cord. Thickened, focal, diffuse, nodular thickening of the dura, and the brain, in the cranium and in the spine. Papers about the changes of these hypertrophic pachymeningitis. This is a case secondary to tuberculosis, as we said. Hypertrophic pachymeningitis could be secondary to autoimmune disease, IgG4, and also secondary to tuberculosis, to sarcoidosis, etc. This case is secondary to tuberculosis, and you can see the thickening involving both the dura of the posterior fossa and of the cervical spine, and the thickening surrounding the cord, anterior and posterior to the cord. Again, from my clinic, 2006, this case of hypertrophic pachymeningitis is confirmed histologically. Again, this case from Japan, 2012, the same thing. You can see here, you can see the thickening of the dura and the compression on the cord. Immunoglobulin-related disease mimicking epidural tumor. So you may think this is an epidural extradural tumor. Again, this is mimicking epidural inflammatory pseudotumor. And pseudotumor is one of the manifestations of this IgG4 related disease. PET scan could be useful. It will show you hypermetabolic reaction, hypermetabolic images. You can see it here. And in this case, you can see it in the lumbar area. They present with the neurological deficits because they are surrounding the cord, they are surrounding their roots. They may present with just backache, they may present with fever. Remember, this is autoimmune disease, and we are talking about vasculitis and so many other things, weight loss and fatigue. If you look at the images, you will find that differential diagnoses include any spinal lesions, and I will prove it to you. It could resemble the myeloma, metastasis, epidural abscess, epidural hematoma, Langerhans histiocytosis. It can go and be similar to astrocytoma, ependymoma, cavernous angioma, lipoma, schwannoma, hemangioblastoma, and metastasis. This is a case of lymphoma. Again, here you cannot differentiate this from IgG4. Transverse myelitis, same thing. You cannot really differentiate. Radiation-induced myelopathy. If you see this picture, you may think this is IgG4, but it may not be. And as I said, that they have this intense reaction to the PET scan. So you can see here the hyperintense lesions. They can look like ependymoma, osteocytoma, subependymoma, oligodendroglioma, enterogenous cyst, epidermoid lipoma, schwannoma, ganglioside neurocytoma, hemangioblastoma, cavernoma, multiple sclerosis, and tuberculoma. So what is the definite diagnosis of this? If we take the Japanese, and they are the masters of this disease, and look at the criteria that the Japan College of Rheumatology have put for us to diagnose, three criteria. Clinical examination showing characteristic diffuse localized swelling, high serum level of IgG4 of 135 milligram per deciliter or above. So the IgG should be higher than 135. And if you take the ratio between IgG4 and IgG, then it has to be more than 40%. This is the definite criteria. And if you look at the histology, then you will find, as we said, the lymphocyte, the plasma cells, the fibrosis, infiltration of plasma cells with IgG4. And if you look at the plasma cells under high power, it should be more than 10 per high power. So these are the criteria of the Japanese College of Rheumatology. If you look at the criteria by Mayo Clinic, put forward in 2015, at least 2 of the 3 criteria, lymphoblastic infiltrate, fibrosis, and obliterative phlebitis. Can CSF study be useful? The answer is no. It is variable, it is non-specific, so the glucose could be decreased, protein could be elevated. You may see atypical lymphocytes and plasmacytes. And some people count this as important, the elevated IgG4 index, more than 5 milligram per deciliter. Maybe the value of CSF that you can monitor the response. So before treatment by whatever means, this is the CSF and serum comparison. And after treatment, this is the comparison between CSF and serum. So it could be a prognostic tool to see the progress of the disease. So let's see now, if you come across a case, how do you think, what is the plan of action? If you have a tumefactive lesions in more than one organ, then you look, is there eosinophilia? Is there elevated IgG levels? If yes, then you will go for specific studies for IgG4. If not, then you can change your mind about it, but images will help you again in showing these thickened lesions. And then you go for the specific studies, IgG4 levels, flow cytometry, and then histopathological studies, as we said before. So this is the way to think about it. The prognosis of these cases, some cases, very few cases showed spontaneous improvement. Don't count on it. Most cases respond well to medical treatment together with surgery. But remember, the hallmark of this disease is high recurrence rate of more than 40%. This is important because you may need to follow your patients all their life. And this is a paper showing recurrence after surgery and steroids. This is the lesion, the meninges thickened, the pachymeningitis. This is with the treatment, and then here recurrence after few years. We were lucky to have one of those cases which we published in the World of Neurosurgery just recently, back in November 2020. But I did not publish it until I had 6 years of follow-up, because it's no good to just publish it after 6 months or so. So we had it about 6 years ago, more than 6 years ago, and we followed it until we are sure, and then we submitted for publication, and it was published in World of Neurosurgery in November 2020. Immunoglobulin IgG4 related hypertrophic meningitis of the spine, a case report and systemic review of the literature. What we did is the largest systemic review of literature ever done for this disease. And this is the paper. And what we did is looking into the database, and we found records 775, and looking from other sources, we had 17. Put them together, we excluded 740, and we ended with 27 records. And these are the cases, and these are the authors. We found 32 cases only, and our case would be number 33. So these are the authors and the year of application. So 32 patients plus our case made them 33 cases. Ages of patients 10 to 52 years, male to female 21 to 12, almost double. So it's a male disease. And looking at the distribution in the spine, we could find that mostly it is in the thoracic or thoracic cervical junction, less in the lumbar, less in the other areas. And what we found through this study is that 6 out of the 33 patients, they had both brain and spine involvement. So if you have a disease like this, you have to do some brain studies. 8 out of 33 patients had systemic disease. Other organs were affected, like pancreas and chest. 13 out of the 33 patients, they had elevated. Mind you, 13. So 20 other patients did not have any elevation of IgG4. Again, stressing this point that this is one of the criteria. If it is elevated, it's good, but you have to look for other criteria because IgG4 could still be normal. 31 out of the 33 patients had surgery because of the neurological deficits they had, and surgery means gross total resection, subtotal resection, biopsy. Mind you, can never ever achieve total resection because it's usually surrounding the spinal cord. 30 out of the 33 patients after operations had received medical treatment. 18 had steroids, and 12 had steroids and immunosuppression. Results of the 33 patients in whole, 20 had full remissions, 9 out of 33 had partial remission, and recurrence is 4. And this is high. So what is the treatment? Treatment is steroids or immunosuppression. Sometimes you can use anti-tuberculous drugs. The prednisolone is the mainstay of the treatment. You can give it IV, 0.6 milligram per kg per day for 3 weeks, and then you continue orally for months, 3 to 6 months. And 50% they respond well to prednisolone. Some cases were just to treat with the prednisolone only, but those were the cases where there was no cord compression or they were unfit for surgery. So prednisolone pulse therapy for remission, prednisolone 1 gram IV for 3 days, and then orally for a few weeks or a few months. Immunosuppressants like azathioprine, methotrexate, cyclophosphamide, rituximab, all these can be used. And this is steroid-resistant relapsing IgG4 treated with methotrexate. So it was resistant to steroids, but well responding to methotrexate. Anti-tuberculous drugs can be used. Again, this is a case report of idiopathic cranial meningitis responsive to anti-tuberculous drugs. That's the lesion and how it disappeared with the case from Canada. Surgery is required if you have patients with spinal cord compression or nerve root compression, and what you can do is laminectomy or laminoplasty, and you remove the maximal thickened dural excision. Again, you cannot remove the ventral dura. This is impossible. You may just do site CT guided biopsy if you are in doubt, or find needle aspiration. Again, back to our case, which we published in the World of Neurosurgery back in November 2020. This man was 27 years when we saw him a few years back. He is Jordanian. He gave history of backache for many years, weakness and numbness in his lower limbs with the frequent falls. He had sensory level at D4, and you can see the weakness in his lower limbs. Reflexes very brisk, plantar upgoing, and he had a clonus sustained at his ankles and knees. And these are his images. This is T1 without contrast, and if you give contrast, you can see these multiple onion layers of thickening. Again, you can see it here. Here, there's nothing left of the cord. It's so compressed. And in addition, there is a syrinx there. So this is the picture and the picture of the syrinx. Looked at his IgG, it was normal. IgG4 was elevated at 220, and IgG4 immunostaining was positive. The ratio was more than 40, 67%, so this clinches the diagnosis. This is the IgG subclass, 220, while the upper limit is 140. ESR was elevated, CRP was elevated. What we did, the other tests like HIV negative, TB, to make sure that we are not dealing with these diseases, ANA negative, LE cell negative, because these are the causes of this pachy meningitis. We have to make sure that it is related to IgG4 and not to other lesions. And now we will show you the surgery. So here we are under the microscope. You can see that we are opening this extremely thickened dura, which does not want to end. You don't know what is underneath. There is no cord, compressed cord, etc. Just being able to reach to an area where we say, yes, maybe there we are closing. But look at this thickness of the dura. So we took a stitch in this dura, open it like an open book. Still thicken the dura. We have not reached to the arachnoid. Here we started seeing some arachnoid, and we are opening the rest of this very, very thickened dura. And I'm showing here that this was vascular. Like any lesion of the dura, it is vascular. So we started cutting these thickened, very thickened dura on both sides. Of course, you would not venture to go ventral to the spinal cord. We just remained on the sides, but it's very, very thickened dura. Again here, you can see here you can see some of the calcifications in the arachnoid, at least in the dura, between the dura and the arachnoid. Having completed the excision, then we used a graft to close the dura in form of a baggy, a dural closure, so that we don't know whether there will be recurrence in the future or not. And we finished by doing that. Okay. Our histopathologist, Dr. Hussam Abfarsakh, looked at the study, and he came with the conclusion that this is IgG4 sclerosing disease and there was no malignancy. And these are the strips, the longitudinal strips of the dura that we have sent him. And he reported dense fibrosis, lymphoblastic infiltration, high Ki-67 index, concentric obliterative phlebitis, lymphoblastic cells, lymphoid aggregates, dense fibrosis, the whole criteria of this disease. T cells with CD positive, 5, 34, 10, and 43. Immunohistochemistry for IgG is positive. So IgG positive plasma cells, and plasma cells more than 40 positive cells per high powered field. So all the criteria, according to the Japanese and according to the Mayo Clinic, this is IgG4 disease. Heavy plasma cell infiltration, plasma cells staining brown, CD138, CD10, CD34. So this is confirmed the diagnosis. And once I finish, if Dr. Hassan Farsakh is there, he can give us his comments on this. What we do also, what we did at that time, because this is a rare disease, we sent the slides to another center in Jordan, the Hussein Cancer Center, and they concur with the diagnosis that this is hypertrophic meningitis. And again, his family sent it to a relative of them in Indiana University of Texas, and again, the diagnosis was confirmed. So we have clinical diagnosis as well. This is the post-operative, no more compression on the spinal cord, still some ventral dura thickened, which is okay. And this is the cord being free of any pressure. And we continued the treatment with prednisolone because we have to. Still, there is thickened dura ventrally. And this is last year, 6 years follow-up. The thickened ventral dura is the same, but the patient is well up and about. Of course, the syrinx did not go as expected. And this is the patient himself on follow-up. So in conclusion, we present the case of this IgG4 disease and wanted to increase the awareness because this will result in early diagnosis and treatment. And this is especially for the neurosurgeon, for the residents, and for the pathologist alike. Remember that this is a disease with a high recurrence rate of more than 40%, and it happens years later. Message here is long-term recurrence is high, so long-term follow-up is necessary. It is a lifetime follow-up. I'll move quickly to the second case for the sake of time. Toxoplasmosis of the spinal cord presenting as a spinal tumor in acquired immunodeficiency disease syndrome victim. Toxoplasmosis is a protozoa, and this is the shape of it, and it's common to get infected with these toxoplasma from the soil, from the cat litter, feces, uncooked meat, unwashed vegetables. They will invade intestinal epithelium and disseminate and insist in nucleated cells, and they lie dormant. And what would activate them? Many things. So the way of transmission is food articles, vegetables, meat, pork, congenital, from mother to baby, blood transfusion, transplanted organs. It can affect children, especially if there is HIV, and it gets reactivated in these patients with AIDS infection. And CNS, in this case, is the most common site of reactivation. So cerebral toxo is more than pulmonary toxo or ocular toxo or even disseminated toxo. In a study from Chicago, 2007, they looked at 264 AIDS patients, and they found lymphoma is the commonest lesion in these patients. Toxoplasmoma came third. And this is the way that AIDS affects your patient. And if you are dealing with an AIDS patient, you have to remember these and look for them by good clinical examination. Nothing surpasses a good clinical history and clinical examination. So look carefully for these findings in this patient. Toxoplasma affecting the eyes, the coronic layer and retinal layers. the vessels of the retina and so on. Again, affecting the ear. So you have to examine your patient from head to toe to look into manifestations of AIDS. Herpes zoster, candidiasis, otitis externa, endocarditis caused by this protozoa, pulmonary changes, pulmonary X-ray changes or CT scan changes and pulmonary embolism, stomach lesions, small intestinal lesions, colonic lesions via endoscopy, and septic arthritis of various joints. So the holistic approach for this disease. Necrotizing fasciitis. Now, we'll back to the point that CNS is affected in 35% of all AIDS patients, 35%. 10% of these, 10% of those affected will develop mass lesions. 10% of the patients with AIDS will develop mass lesions. And cerebral toxoplasmosis in particular is one of the commonest manifestations of AIDS patients. It comes at the gray-white matter junction, affecting basal nuclei, cerebellum, brainstem, and spinal cord. So spinal cord is the least affected. Brain, as we said, is more affected, and it can manifest itself by necrotizing encephalitis, coagulative fibrosis, abscess formation, etc. In another study in San Francisco, 2007, looked at the 320 patients with AIDS. They looked at what is the commonest lesion. They found primary lymphoma, followed by toxoplasma, followed by encephalitis, followed by infarction. Another paper, 264 patients from, again, Chicago. They found that lymphoma comes first. And this is the toxoplasma affecting these patients, multiple lesions or single lesions, look like abscesses, etc. It can affect the spine. Spine is much less than the brain. That's why we're presenting this case. It is rare. So toxoplasma encephalitis manifestations or the primary CNS lymphoma in these AIDS patients. So our case is toxoplasma of the spinal cord. Also, we presented this after long follow-up. We don't like to present cases after a month or 2 months. We need to have a few years of follow-up before we publish them. And this was published into Insights in Neurosurgery back in 2016. Cervical spinal cord toxoplasmosis in a patient with AIDS. And here's the paper and the references. This patient is a 35-year-old male patient from Syria, neighboring country to Jordan. And that was before the civil war in Syria, many years before the civil war in Syria. Funny enough, this man worked as a clerk in the judicial court. So he's a very respected member of the society. He gave us no history of alcohol ingestion or drugs intake. He's a heavy smoker. He's married, happily married with 2 children, and he denied any extramarital affairs. This shows you that sometimes you are deceived by your patient. He presented with quadriparesis, with a sensory level, positive Babinski sign, and his systemic examination was unremarkable, except that he was cachectic, he was low weight. So this is in his right and left upper limb, more weakness on the left side. In his lower limbs, again, more weakness on the left side, brisk reflexes, upgoing planters. Images that he brought from Syria and he refused for us to repeat. They were low quality, but because he was hard in money, he did not want to put more burden on himself from the financial point of view. And he said, these images are okay, although they were low quality, but we accepted them. Again, this is T1 before contrast, and this is after contrast, and this is T2. For all intentions and purposes, for me, this was an intramedullary spinal tumor differential diagnosis between ependymoma or astrocytoma. And there's a very famous statement by Jack Brucci, who has done most of these spinal cases. Jack Brucci from Belgium, who was the president of the World Federation, mentioned that you do not diagnose from the MRI. If you diagnose that this is astrocytoma, it would turn out to be ependymoma. If you diagnose ependymoma, it would turn something else. So the best thing is to go and excise it. He is totally against biopsy and referral for radiotherapy. He considered this as a crime against humanity. And this crime against humanity is practiced every day in various parts of the world, biopsy and radiotherapy. So this is the lesion. It is totally intradural, more on the left side, as you can see. These are some clips from the surgery. This is us opening the dura, and you can see that the spinal cord is very thickened. Here we have opened the cord in the posterior part, opening the posterior sulcus. People call it myelotomy. Jack Brucci, I, and many others against this terminology because you do not do myelotomy. You do opening of the posterior sulcus. If you open the posterior sulcus, you are not doing any myelotomy at all. And how would you know that you are in the midline? You look at the rootlets, and you just take the middle between them, and anything that is crossing the midline, you can coagulate with very judicial use of the coagulation. And then you go between the posterior columns, and you can see the vessels going inside parallel to the surface. Let's see the surgery. Here I'm opening the dura. This is one way of opening the dura. So many ways of opening the dura. Maybe if we have time today or the next time, we can show you. And I open the dura alone and the arachnoid alone because you need to close them later on. So here is the cord. This is a flattened cord. You take a stitch here so that you divert. And then here you try to find the midline. Now with a tumor inside the cord or a lesion inside the cord, you don't know where is the midline. So you have to use your senses and make sure that you open the midline. And the way to know that is to centralize yourself between the rootlets here and there, and you can see the blood vessels going in, so you are in the midline. So what did I find? I found this tumor, which for me, for all intentions and purposes, looked like an astrocytoma. I just continued taking it off. I could find a good plane of cleavage there, so I pursued that. And what I did is to send a biopsy, and to my utter surprise, my histopathologist, Dr. Farsakh, said this is a parasite. This is a protozoa. By the time he gave me the answer, I was well into a good excision of the lesion. So I stopped there because I knew that the treatment here will be medical. So I did not know the diagnosis before going in. I only knew the diagnosis after my histopathologist gave me the answer. So you can see this is gelatinous, very much like astrocytoma, maybe a high-grade astrocytoma. This is the plane of cleavage between the lesion and the tissues of the cord. Okay, so Dr. Hassan Farsakh, the histopathologist, confirmed this, and he did, of course, all the other staining: cytomegalic virus, herpes simplex, Ziehl-Neelsen, PASS stain for fungi, Giemsa stain, and he found toxoplasma. And this is what he reported. Bradyzoids encased, as you can see, in the tissues, and a lot of lymphoid tissue around as inflammatory reaction. Bradyzoids, as you can see, with a lot of cells and free protozoas inside the tissues. Again, tachyzoids, as you can see here, in a cyst. It's more defined picture. Again and again, showing these pictures of various stages of growth of this protozoa. And this is Toxoplasma immunostaining. So, having, in retrospect, you are very, very wise, of course. So, although I resisted the idea when I was in theater, when Dr. Farsakh told me that this is a parasite, this is a protozoa, yet I had to concur to his diagnosis, and I stopped accession, removed as I could by the time the frozen section came back, closed the case, and patient was well. So we had to make sure that this patient having this disease. So we thought of AIDS, and indeed we did his PCR, and it was very high. He was positive, and when he was positive, we asked his wife to submit herself to the test, and she was negative. She did not know why we asked for that test, because we could not tell her. He asked us not to tell her. Now, the Toxoplasma IgG was elevated, 3.44, while the negative is 0.9, so it is definitely indicator. So this patient was the problem. He had very high load of the AIDS. It was very advanced, so we thought that his life expectancy is very short. He had severe immune deficiency. His CD4 T lymphocytes were few. He was in cachectic state. His weight was 37 kilograms, and he had HIV nephropathy with elevated creatinine. So for us, he was a problem. What should we do with his medication? Should we give him the treatment of AIDS? Of course, to confirm the diagnosis further, we went into his brain and we looked at these lesions, and this, of course, confirmed the diagnosis. This is definite diagnosis. So the treatment for these cases is the heart, abbreviation for highly active antiretroviral therapy, and he was treated by my colleague, the infectious disease specialist, Dr. Montasser Belbisi, and he gave him sulfadiazines, pyrimethamine, and the heart in form of Nelver and Diover, antiviral. He started off with trimethoprim, sulfametazole for 6 weeks. He gave the heart. Within 6 months, the HIV titers were less. His CD4 increased. His weight went up from 37 to 53. And long-term follow-up, we kept looking after him until we could not reach him because of the war in Syria. So this is the summary of his treatment. As I said, the antiviral, the Bactrim, picozyme, and clindamycin. Some people prefer this regime. Others would use the different regime. It's just the same. Excuse me. But it's just the same idea. Following him up 6 months after surgery, his HIV PCR became negative with no HIV copies at all. And his first day post-operative showed that we have good job. We have removed some of the lesion. This is the central opening of this of the posterior sulcus. Again, no myelotomy. Myelotomy should be dropped from our terminology in these cases. 6 years we followed him up, and there was no recurrence. He was well, his cord was well, and he was up and about. And he promised us that he would cut any extramarital affair. And he learned his lesson in the hard way possible. We also did the brain MRI, and his lesions disappeared completely. And as I said, this is follow-up his cases. I don't think we have much time to take other cases. I have plenty. So what I suggest, John, is that we stop here. We take questions and comments. And next week, we will continue from where we are And next week, I'll present a very interesting case of intramedullary schwannoma, extensive hemangioblastoma, so many other interesting cases. So I'll stop here and I will take your questions.
Hey, that sounds like a great idea, Dr. Sabaya, and I'll turn this over to Radab.
Yes, Dr. John. Professor Ibrahim, thank you so much for this tremendous work. It's really interesting topic to be talked about. And we are very happy to have your shared experience, which is very unusual to be shared and to be presented in this beautiful way. So I think there was a questions by Dr. Harshad, who just asked my question also, that he asked you, doctor, do you use electrophysiological monitoring sensory and motor epoch potentials during your operation on the spinal cord?
If needed, yes, but most of the cases and most of the authors would tell you that with intramedullary lesions, it has no value. Even if the sort of things went wrong, it will be alert at the last minute and it will not benefit you. So I use them in very limited cases, but not in all cases.
Okay.
Dr. Victor Hugo, he said he has a case to present, so it would be nice to see his case of toxoplasmosis. Victor?
Hello, Victor.
Yeah.
Do you have that case that you talked about?
Well, this lecture was really impressive. I have never seen something like this. And because you have combined surgical procedure, histopathology, immunology, you have made a big effort to giving us this opportunity to see this really amazing lecture. So once the video could be edited, I like to put it in several groups to show, because I think everybody in the neurosurgical world have to see this excellent lecture. Thank you, dear friend Ibrahim.
Thank you very much indeed for your comments.
Yeah, maybe next week you can bring him, Victor.
Yeah, we can, yes.
Okay,
I have a
go ahead. Hussam,
Dr.
go ahead.
Hussam Farsakh is our pathologist. He surprised me. I was in theater operating on this toxoplasmosis. I thought that this was astrocytoma, and I was shocked when he said this is a parasite. You better stop. So I did stop, but I was not happy. And when he produced the evidence, I had to submit to his experience and to his vast experience in this. Thank you, Hussam, again.
Thank you very much, Dr. Ibrahim, for these very interesting cases. I would like to actually clear some points. These two lesions that presented by Dr. Ibrahim very clearly, they presented to the patients as a tumor. And it was very difficult at the time of the frozen section to convince the surgeon that this is not a tumor. I think the cooperation that I have with Dr. Ibrahim allowed me always to convey my message to him, and I always see his respect to our communication. And this is really what makes the cases very interesting and interactive between each other, and highlights how the good communication between the pathologist and the surgeon really can bring the best to the patients, especially in rare cases. I would like to mention one important point. In both cases, actually, we had to wait for some time to bring the immunohistochemistry, because this was the first case to be reported in IgG4. We have to bring the IgG4 immune stem from outside, and I requested Dr. Ibrahim to allow me for this delay, and he accepted it with all relief and kindness. And the second case also, I asked him, we want to confirm it, because we cannot say toxoplasma without bringing the antibody and doing the immune staining. And he also called me, take your time and give me an exact diagnosis after you confirm it. I think if it was another surgeon or another doctor, other than Dr. Ibrahim, probably he will not accept, because I had this experience with other doctors, they will not accept that, yes, we want to buy another antibody and to cost the patient extra amount of money, but because he really wants everything to be perfect, and this is, I think, very thankful for Dr. Brahim Speih to this point, because he wants everything to be perfect 100%. He allowed me to bring this antibody, and it took me about 2 months for both cases to confirm the diagnosis, and made a lot of changes to the patient. Once you diagnose something very, very rare in something that is reportable, you really have to be 100% sure. You cannot just say, I think, or I guess, because this is a thinking of something that's going to change the patient's type. For example, in the patient's IgG4 related sclerosing disease, the patient, when I told Dr. Brahim that I suspect this patient is IgG4, he sent the patient to my lab. I examined the patient. We did some blood test IgG4, and I actually, after we did the immune staining, I finished my diagnosis, and I did not know the follow-up of this patient who came to me with the staggering walk. It was really very difficult for him to walk. But when he presented the case about 10 years later, I really forget what happened to the patient. He presented how really he improved dramatically. So I felt very grateful that Dr. Brahim allowed me to finish everything according to the best of our standards of work, because this really changed the patient's life and made him, treating him made him to be a normal person rather than to be handicapped person. Again, I think these rare cases needs a very good cooperation between the surgeon and the pathologist, and both of them, they have to respect the opinion of each other and to work to the best of their patients. Thank you.
Thank you, Assam. I see Dr. Abdurrahman Jdifat among the audience. Are you there, Abdurrahman?
Yes, sir. Thank you very much, Professor.
Can we hear your comments and views?
Yeah, please. Good evening, everyone. Thank you for this nice presentation. I'm happy to hear that these rare cases we don't see in our common practice, and I'm very impressed by this collaboration between you and your pathologist.
Yeah.
But my question is regarding the toxoplasmosis case, where you mentioned, if you back to your slides, that IgG was high, or the titer of antibody IgG. In this case, I think this should be immune patients. So IgG, I think it's IgM, if I'm not wrong. So you said IgG, so I think it's IgM, because IgG, you are immune. So this is antibody, this is good thing. But in this case, this is active disease. So I guess it is IgM. Second point regarding the period of follow-up for these. Actually, I'm impressed by the prevalence of these cases, 30 something in 10 years, and it is a rare disease, this pachymeningitis. So if we are, do you think this underestimation from our side, or this is just looking for these cases, you will find it, or the referral, problem in referral, because you know Jordan population is low. We know that there is referral from surrounding countries, but it is still, for me, it is not explained by this high incidence or prevalence during this short period of time. And thank you very much.
Thank you, Abdurrahman, for your question. Indeed, and I agree with you totally that there is underestimation of the IgG4. I, for one, when I went in for this patient, I thought I'm dealing with a meningioma. It did not cross my mind that this is an IgG4. The number of cases in the literature is far in between, so it does not click in your brain. So it is definite underestimation. And just a couple of months ago, I had another case referred from Iraq to me as an intradural extramedullary meningioma. Again, it looked like IgG4. Did all the tests with my rheumatologist, Dr. Hassan Nadaf, and indeed it was. So this patient, who was almost paralyzed and coming for surgery, went back home walking only on medical treatment. So it makes a lot of difference to diagnose before you jump into surgery and so on and so forth. It is underestimated. People don't know about it because it is not that mentioned in literature. And between 2003 and now, only 32 cases, and my case is the 33rd case. So it is rare, but it is underestimated and underdiagnosed.
Can I comment on the
second question?
Regarding the IgG, well, I cannot.
Can I comment on this one?
Yes, please, Hassan. Yes.
Yeah. Yes, IgM indicates that it is a recent infection, but IgG will rise even if the patient is active. IgG, we see it in many infections in the lab, even if it is active. That means that this has been there for some time, not within 10 days or 20 days, maybe more than this. Does not mean the patient is immune. This is very important. The presence of IgG does not mean the patient is immune. It means that it has been there for some time. When we see this in many viral and bacterial infections.
No, this is, thank you, Dr. Hussam. But, you know, it is immunocompromised patient. So the immune system to produce this high amount of IgG, this is, with this infection, so it is, can it go in parallel that he is immunocompromised and is still producing antibody against toxo?
Yeah.
I mean, this.
Yes. Let's remind you that in HIV, the problem is in CD4 cells. The CD4 cells is not in the antibodies production. It's a particular type of cell because immunity is not only dependent on antibodies, dependent on many things, other things. So it can be in immunocompromised. You have some impairment in the immunity, but other parts of the immunity cannot cooperate with other parts to get rid of the infection. That's why they are getting this infection. So this does not mean immunocompromised patient will not have a high IgG. No, this is not right. We see this all the time in CMV patients with that kidney transplant. The CMV will be high and they are immunocompromised. So you cannot really make this as a statement that immunocompromised will not have higher IgG. No.
Yes. I see Dr. Agrawal in the panel.
Yes,
are you there,
he has
Dr.
a
Agrawal?
question. Yeah, he's been very patient. Abdul, go ahead. Abdul Rahman, go ahead.
No, thank you, John. I finished my comments. I have
Dr. Agrawal from India, because this is most of the cases also, some of the cases reported in literature came from India. Are you there, Dr. Agrawal?
Go ahead, Abdul Rahman. Do you have something to say?
Abdul Rahman did ask his question.
Oh, okay.
Dr. Ibrahim, maybe
Yes.
Dr. Omar Al-Ammar has a question.
Yeah, please.
Okay, thank you very much,
Hey,
Dr. Ibrahim, Dr. Ibrahim, and all the colleagues. Okay, first question for the when surgery for midline during the intact area of the tumor. I think we must do the normal anatomy between the two arteries and come down. I think that, of course. And
Yes, as I said,
okay.
People still speak about a posterior myelotomy. This is wrong terminology to use. There's nothing called posterior myelotomy. You are opening the posterior sulcus, and if you open it in the midline, you will see the gracilocunate, the posterior element. So you will see the blood vessels going in. You can see them on both sides. So you know you are in the midline.
Yes.
And another landmark is you look at the exit of the rootlets. So rootlets coming this way, rootlets coming this way, you take the midline. Also looking for the central blood vessels. So it's a combination of so many things to do, proper opening of the posterior sulcus. So this is important. We should not speak at all about myelotomy. It is not on. This belongs to dark ages. We should drop it completely. The other thing that we should drop, and this is still being practiced in this area of the Middle East, people would go and do laminectomy one level, although the tumor is extending several levels. They just open, take a biopsy. Oh, this is ependymoma, refer for radiotherapy. This is a crime. It should not happen. Biopsy and radiotherapy, be it a spine, be it a brain, being anywhere, is a crime against humanity.
Second things, please, Ibrahim, and I will thanks all and the regards for you. I think this is a good criteria. Good surgery needs team, for good surgeon, good pathology, good radiologist, and good after that, good outcome.
Absolutely.
Thank you very much for you for this. Thank you very much for you.
Dr. Sabea, Omar's calling from Syria.
Yeah, oh yeah, I know. Idlib, yes.
Oh, okay. Just want to let people know.
Sure.
Okay, more comments, questions? I'm sorry, Abradab, I'm taking over.
At all, Dr. John, my pleasure.
No, go ahead. Go ahead. Anybody you want to call on or something?
Actually, Dr. Sabea, I have a question, if you don't mind.
Sure.
Regarding toxoplasmosis, have you ever passed through cases which are not AIDS patients, like toxoplasma on non-AIDS patients and
Yes,
HIV?
of course. Yes, yes. It is reported, and I came across one case only, and it was no immunocompromised patients. It was just infected from dirty cat. This man had a cat at home, and it was dirty, and he got the infection from there. Like the hydatid cyst, it is common in the Middle East because we come across the dogs and the sheep, and we touch them, and we take the disease. So yes, it can come from just direct ingestion of the protozoa through infected material.
Okay, and in those cases who are non-AIDS patients with toxoplasma, would differ in histopathology or in the pathology all in all, like toxoplasma AIDS patient different from toxoplasma
No,
AIDS
not
patient?
at all, and I believe that there is no difference in pathology between this and that. And I will also ask Dr. Abu Farsakh if he can confirm this. Dr. Hassan, is there a difference in pathology between toxoplasmosis in AIDS patients and non-AIDS patients? Hassan may have left. Anyway, I believe there's no difference.
Okay, thank you.
As I said, I have so many cases. Time took us by surprise. So I think we'll stop at 2 cases, but next time I have more interesting cases of intramedullary schwannoma, of very extensive ependymoma, of extensive hemangioblastoma, of intramedullary tuberculous lesions, and so many other cases. So I hope even next time that time may be not enough, but we will continue doing this until we finish all these interesting, unusual intradural cases.
Very good. We look forward to that. Okay, Radab, I think it's ready for time for the infamous Kahoot quiz,
Yeah.
which Dr. Sabea has made 10 questions from the body of the presentation. And Radab, I don't know if I can take the excitement.
Yes,
Okay,
sure, you can do. You're happy neurosurgeon, Dr. John.
Okay, I put now for all the panelists, including Dr. Sabea and Omar, it's you use a smartphone, and the code is in the chat box. It's 138. You go to kahoot.it and go to 138-9623, and that brings you into the Kahoot platform, like I'm going to show you. Okay, we're about that. See now, 138-963. You can see that okay, Dr. Sabea?
Yes, yes, indeed.
Okay. Yeah, that's, and as soon as we get some people here, you can see who's entering here because you're given a name. It's anonymous. Nobody knows who anyone else is. So, okay, we got 3 people. I'd like to start when we have around 6 at least. We'll give it a second to come in. So for 4, we'll have a few more in. I'm getting 1, 2, 3, 4, 5. Okay, one more. Oh, one more and we'll start. Okay. And you know, once we get good at this, Dr. Survey, I think we'll have more people participating. I put the link on the Facebook, but
Yeah, yeah.
not getting too many. Well, I put the wrong link first.
No,
But
but
now
people are shy to participate, but gradually
Yeah.
they would get to that. They are not exposed. Nobody knows their identity. It's just a mental exercise.
Yeah, this is totally anonymous. Yeah, why don't we start? We can start. Someone, I'm sure people will come in
Sure.
as we go along. Okay. You can see it okay, right?
Yep.
Okay. And you vote on your smartphone with A, B, C, or D. We have 20 seconds to answer. And you gotta vote with your smartphone. Okay. That's the right answer, correct, Dr. Svea?
No, the right answer is lymphoma, actually.
Okay,
Toxoplasmosis
lymphoma.
is
C.
common, but lymphoma is the commonest. So C is the correct answer.
Okay, very good. We're learning. Okay, 2 got it right. Okay, next question. Let's see who got that question. Friendly Bison got it right. Okay. Victor, I hope you're playing. Okay,
White matter,
well,
I think. White matter.
Uh-oh. What's
So
the correct answer, Dr. Sabir?
The correct answer is basal ganglia. As we said, the brain is more than the
Okay,
spinal
okay.
cord, and in the brain, basal ganglia is more than the brainstem. So the correct answer is basal ganglia, followed by brainstem, followed by the spinal cord.
Okay, very good. Yeah, the basal ganglia is not
Yes.
even in the brainstem, right?
Okay, okay, yes, yes.
Okay,
Yes,
next
yes.
question. The
I
friendly
need to go
bison,
open the
smart,
cohort.
smart goat is taking the lead. Okay. And hypertrophic pachymeningitis.
Meningitis.
You got a good chance of a guess on that one. Okay, I hope that's the answer, Dr. Surveyor.
Yes, the good answer is the cranial
Okay.
pachymeningitis is the commonest, and so many papers are presented in literature about the cranial pachymeningitis and less papers on the spinal.
Okay, very good. Okay, I'm glad to see we got that right. So retallying, Friendly Bison takes the lead again. Hemiangioblastoma of the spinal cord is
Spinal cord. Most common spinal cord. Most common spinal cord. Rare. A.
So
Okay.
C is the correct answer.
Great.
It is not rare, but it is the third most common spinal cord lesions after ependymomas and astrocytomas.
Very good. Okay, that's 2 in a row we've got right. So Speedy Deer has forged into the lead for the first time. 5th question. Hemiangioblastoma of the spinal cord and associated with Van Hippel-Landau disease.
What is the question? One level of many cases.
Okay.
The correct answer is C. It is not that common with the von Hippel-Landau disease. The cases that are solo without von Hippel is commoner than the cases with the Van Hippel. So associated with the von Hippel-Landau disease in the cranium and in the spine, it's just 25%. So C is the correct answer.
Okay, very good. See who took the lead. Smart Goat is back in the lead. Okay, sixth question. An AIDS patient CNS is affected in okay, Well, is that a correct answer? Okay, the correct answer is no one got that right.
The correct answer is that AIDS patients, CNS is infected in about 30% of cases. So the
Okay.
correct answer is C.
Oh, that seems a little low.
Yeah.
Okay. Let's see, what question is this? Okay, smart code is forged into the, okay, 7th question, recurrence rate of hypertrophic pachymeningitis is recurrence rate.
Yes.
Okay, 3.
The correct answer is 3. It is very high, and that's why we have to keep following the patient for their lifetime. You
Okay.
don't just sleep on those patients because it can come back anytime. It's 40% recurrence rate with surgery and with steroids and with immunosuppression treatment. So keep looking after your patients all their lives.
Okay, very good. Okay, this 8th question, the D choice means all of the above, okay? I didn't put the, okay, if you see the D is all of the above. It's not autoimmune. It's all of the above is D.
It's all of the above.
Okay,
Yes, correct.
most people got it right.
Yeah.
It's just, okay.
It's not only IgG4, it can be tuberculosis, sarcoidosis, infection, radiation, post-radiation, post-operative trauma, so many causes for hypertrophic pachymeningitis.
Very good. Okay, let's see who took advantage of that question. Okay, smart code is widen the lead. Okay, the 9th question, same thing. D is all of the above. It's not liver biliary system. It's all of the above.
Correct. It's all of the
Correct.
above.
All of the above. So everyone got-
Pituitary, liver, pancreas, lymph nodes, and so it can affect any of these structures.
Very good. Okay, last question. Smart code maintains the lead. Best line of treatment. Okay. Okay.
The correct answer, prednisolone is the preferred one. Dexamethasone is not bad, but prednisolone has the upper lead. So it's a correct answer is C.
C, okay. Let's see who's going to take home the bacon. What the bacon is, I don't know. I don't know what the prize is this week.
Just
Smart code. Smart code can reveal their identity only if they want to.
Absolutely.
If they don't want to, they don't have to.
Thank you very much, John. It's me.
Oh, who is that?
Pragnesh Bhatt, and this is despite of the first question answer being wrong. So if that answer was...
You were the winner, I think, last time too.
Yeah, I keep winning. Yesterday I won World Spinal Congress and I won that twice.
Excellent.
Okay, you got a free trip to Miami Beach. Well, you'll stay at this hotel here.
Yeah.
Thank you. I would rather visit Professor Siba unit and learn something from the master.
Oh, go to Amman, Jordan.
It's a pleasure to have you with your family. Be my guest.
Thank you very much. Thank you.
Okay, very good. Okay, we'll end this webcast. And next week, Dr. Sabeh, you're gonna.
Yeah, next week, Wednesday at 7 o'clock Jordan time, 5 p.m. Greenwich Mean Time. We will continue presenting these unusual
Thank you very much.
spinal lesions. Thank you very much, all. Thank you.
Thank you very much.
Thank you very much, all.
Thank you, Dr. Sabeh. Thank you, Radab.
Thank you, Dr. John. Thank you, Dr. Brian.
And now hang around now if you want. You can network. So we'll see you next week, but stay here if you want.
Thank you.
Okay, thank you. I'm going to stop recording.